This week on Empowering Midlife Wellness, I'm talking about all things to do with timing of menopausal hormone therapy. When should I start it? Do I have to stop it at a certain age? When is it too late to start it? We're going to dig into everything surrounding that topic today. Hi friends, and welcome to this week's episode. If you're just joining me, I'm Dr. Susan. I'm a board-certified gynecologist and certified menopause practitioner dedicated to helping women in perimenopause, menopause, and beyond live their best life ever. And I never get tired of talking about menopausal hormone therapy. Today I want to talk about a question that comes up all the time, which is regarding timing of menopausal hormone therapy. Specifically, when should I start it? When is it too late to start it? When should I stop it if I've already started it? And everything in that bucket. So let's get into that today. So like everything in hormone therapy world, a lot of our data comes from that Women's Health Initiative study that we're all very familiar with now. It was stopped over 22 years ago and scared everybody about the possible risks of hormone replacement. And we know now that we do not need to be scared of menopausal hormone therapy. However, I want to talk a little bit about that story because it explains why some of these ideas came about. For example, that you can't take it when you're over 60, that you should stop it after 10 years, or various other iterations like that that you might still hear because this is what physicians were taught not too long ago. So just quickly going back to what was found in the Women's Health Initiative study. I've talked about this many times, so I'll go over it very briefly. Remember that these women were an average age of 62, 63. The reason why is that the primary outcome measure that they were studying was heart disease, because in the past it had seemed very likely that estrogen reduced the risk of heart attack. So in order to see if we could prove if that was the case, this study was taken about in order to look at that, as well as some secondary endpoints like breast cancer. So that's what they were looking for. And interestingly, even using products that we don't use anymore, including Premarin, which is the type of estrogen that's retrieved from horse urine. So it works very well for side effect relief, but it's very different than bioidentical estradiol. It's pro-inflammatory, has a lot of other effects in our body that we don't necessarily want. And they also used Provera in a subset of patients, which is a synthetic type of progesterone, which is also pro-inflammatory and has a lot of other side effects that bioidentical progesterone doesn't have. Well, why did they look at women who were more than 10 years past menopause? Well, they included women who were in their early 50s and all the way up to 79, but again, the average age was in the early to mid 60s. The reason being that if you're doing a study on heart disease and you've got a certain amount of time, they had 8 years, they needed to see some heart disease in order to prove if one group was different than the other. So choosing a younger group of healthier patients, they wouldn't have seen any difference because that risk of that disease is so low in that population, if that makes sense. Another thing, it was a very well-designed study in this way. They excluded women who were younger and having hot flashes, night sweats, etc., because part of the study design requires that you don't know what you're taking. So if I'm having a bunch of hot flashes and I'm in a study and I'm given a pill and all of a sudden I feel better, I know that I'm in the treatment arm. On the other hand, if I'm taking something and I don't feel better, I'm going to pretty quickly find out I'm in the placebo arm. And the problem is people drop out of studies when they are in the placebo arm, naturally. So it's really important that they don't know. And so, of course, they couldn't give it to those women, and hence another reason why they chose an older population. But suffice to say, this wasn't women who were starting hormones right after menopause, which is usually the discussion that we're having now. It was a totally different group taking a different product that we don't use anymore. That being said, they had some really interesting findings in the group of women who were younger, and there were some in the study, and the women in their 50s, they showed a reduction in heart disease, which was not unexpected because, like I said, that's what we kind of thought from previous studies that would be the case. Now, in the women who were over 60, they saw an increase in heart disease. Well, it wasn't very much, and it also was only in the first year of treatment, which is very interesting and suggested that that particular group of women who had a heart attack on estrogen or the combination already had pre-existing heart disease, and something about the medication caused that plaque to rupture and cause a heart attack. It didn't cause it to form, in other words. The fact was it was already there, because after the first year, no difference was seen. So the thought process became then that we shouldn't give estrogen to women who were 60 or older because that would increase their risk of heart attack. Well, there's a lot of things wrong with that statement. One is, what kind of estrogen are we talking about? Of course, Premarin's very different than bioidentical estrogen. And also, what about if a woman who's 62 wants to take estrogen and she's got a perfectly clean heart based on a cardiologist's evaluation? So we have to look into it a little bit more than just saying blanket no, because that's applying to a population, not to an individual. And we really want to think about tailoring hormone replacement to your individual situation. All right, so remember, the best piece of information that I said already was that the women under 60 had a reduction in heart disease, even though they were taking the most horrendous type of hormones that we don't use anymore. Even so, they still had a reduction in heart disease, which was very important information. And then the increase in heart disease in these other women was because they had existing heart disease combined with the fact that they were taking a very pro-inflammatory type of hormone that we don't use anymore. Okay, so that being said, another study was done called the ELITE trial that specifically looked at early versus late intervention with estrogen. And early was giving it to women who had been in menopause for 6 years or less than 6 years from their last menstrual period or from menopause, and another group greater than 10 years. So it was really breaking apart that question. And what they found was very interesting, and that is in the younger women, there was a reduction in heart disease as expected, and pretty much has shown up in every study ever done. In the group who started it later, there was no difference. And so that's really interesting. It did not show an increased risk of heart disease. It showed no difference to placebo. So for sure, in the older group of women, there was not the benefit for reducing the risk of heart disease. That is true. But there also wasn't an increased risk. So I think that's very interesting. I think we can stop saying that if you start taking estrogen when you're 60 or older, it increases your risk of heart attack. That is not capital T true. It may do so if you take Premarin and you've got existing heart disease. But short of that, there's no evidence that that's actually the case. Now, the other two hormones that we frequently talk about, progesterone and testosterone, are not even involved in this conversation, so I'm going to kind of leave those out today because there's no controversy about timing regarding those two. If there is any controversy regarding timing, it's about estrogen, so that's why I'm focusing on that particular hormone today. Okay, so we know if we start it, now in the ELITE trial it was less than 6 years was beneficial, and 10 years was neutral. So we can assume that the in-between was somewhere in between beneficial and neutral. So I think that was a very good study design. So if we can, we want to start on it as soon as possible. In fact, in the first few months, because we get the most benefit when we start it early. The reason being is that estradiol, bioidentical estrogen, is highly protective for the heart and the brain. It's really good for our blood vessels. It's anti-inflammatory, it keeps the blood vessels very supple, it lowers our cholesterol, it reduces platelet aggregation, which is one of the things that leads to heart attack. So lots of positive effects, and we don't want those changes to already happen because they're essentially not reversible, which is the reason why we don't see the benefit in women who've been depleted of estrogen for many years. That makes sense. Now, another finding in the Women's Health Initiative was that taking estrogen by mouth, along with Provera, increases the risk, tiny bit, very small amount, of blood clotting issues like a stroke. So if you get a blood clot in your leg, it can travel to your lung, that's a pulmonary embolus, or to your brain, which is a stroke, terrible things. We know that taking estrogen by mouth can increase that risk. Even in young women taking birth control pills, there's a minuscule risk of those terrible things. So if we give it in a not by mouth form, that would be a cream, a patch, a pellet, anything that's not a pill, that risk seems to be negligible. So in the old days, when estrogen was given by mouth, there seemed to be a slightly increased risk of those blood clotting disorders. Nowadays, that it's given transdermally, that does not seem to be the case. So lots of big studies have looked at that. Now, granted, none of them have been big randomized controlled trials, but all of the observational studies and what are called meta-analyses that look at different observational studies suggest that is the case. So we're not worried about increasing the risk of heart disease. We're not worried about the increased risk of stroke, no matter how old you are. Now, of course, both of those have a baseline risk. We're walking around with a small risk of those things, but the question is, does estrogen make it higher? And the answer is probably not. Now, in an abundance of caution, and you should do this anyway because it's just a good idea, before taking hormones, have your heart checked out. Make sure that you don't have any buildup in the heart, and then it's kind of a moot point as far as whether a existing plaque could be disrupted by estrogen or not. Just make sure you don't have any. So go to the cardiologist. They can do what's called a coronary artery calcium scan, or even what's called a CT angiogram to check your heart out. And if it's clear, then that is not a problem for you. In fact, it's probably not necessary to do that because we're not taking Premarin, but still, it's a good idea, and we should all do that when we're around 50 anyway, in my opinion. So we talked about heart disease, we talked about stroke. The last scary thing that they found was that it seemed in the Women's Health Initiative study that the older group of women had a very slightly increased risk of Alzheimer's disease. And that was very, again, unexpected because previous studies had suggested the opposite, that taking estrogen would actually reduce Alzheimer's disease. And in fact, it does, again, in the younger subset of patients. The reason is very similar. We often say whatever helps your heart helps your brain, because heart disease and Alzheimer's disease, all forms of dementia, are in the beginning diseases of perfusion. They're vascular diseases where our blood vessels are not perfusing the brain properly. In the case of Alzheimer's, that lack of perfusion causes proteins to misfold, and we get those what are called tau tangles and amyloid plaques that are the signatures of Alzheimer's disease. But prior to that, the thought process is it all started with a problem with perfusion. So, stands to reason, if we can keep our blood vessels healthy, it's going to reduce that risk. So, pretty much all the studies that have looked at younger women taking estrogen suggest that that is the case, that not only cognitive decline, but actually dementia is reduced if we start estrogen early. Now, does taking estradiol when you're 60 or 62 or 65 or any age more than 10 years past menopause increase the risk of Alzheimer's? Based on the Women's Health Initiative, you might say yes. I think with bioidentical estrogen given in the right way, there's very little, if any, evidence to suggest that's the case. So I would definitely look at that on a case-by-case basis. And if a patient presents to me, which happens all the time, and she's over 60 and was not given the opportunity to take menopausal hormone therapy because her doctor told her not to, and now she wants to reevaluate that idea, it's really important to look at this on a case-by-case basis. So the first thing I would assess with you is why you want to take it at this point. What benefit could there be for you? Well, it's very possible that you might be 62, 65, and still having hot flashes, night sweats, vaginal dryness, sleep problems, mood problems. Those things often don't go away. They can last for 20 or more years. And so that patient could really benefit from estrogen. And if we've evaluated that her heart's healthy, we know transdermal estradiol does not seem to increase the risk of blood clotting events, that could be a possibility for that patient. On the other hand, if she's not having any symptoms and she's feeling fine, the question might be, well, why are we starting on hormones? What benefit could it provide? Certainly it might provide benefit for the bones. Now, the parties who disagree with hormone replacement would say, well, you could take other drugs for your bones. Yeah, you could, but they have a lot more side effects. So if we're worried about side effects of estrogen, we've got to think about what the side effects of other bone builder drugs are, which are significant. So, it's curious that hormones have really gotten such a bad rap as far as being microanalyzed for any type of side effects, where other prescription drugs are just written without a concern. I think we need to really look at each and see what the benefit and risk of each is, and then make an educated decision. So the point of this whole conversation regarding age and time is around the conversation about whether taking hormones when we're older increases our risk of heart disease, stroke, and Alzheimer's in particular. So we've talked about all three of those, and long story short is, if it's given in the appropriate manner, to the appropriate patient who's been evaluated for all of those issues to see what her risk is, the answer is not capital N-O, no. It shouldn't be. Anyway, it should be, let's see. Let's evaluate you individually and make a decision that's best for you, because just making a statement based on a population of patients makes no sense for an individual. Another question, which is related, but it's often been tied together and it really shouldn't be, is do I have to stop taking hormones at a certain age? Well, that all got kind of muddied and mixed up when people started saying things like, you can't take hormones when you're over 60. Now, that was regarding the conversation of starting hormones. It got kind of extended to say you can't take hormones when you're over 60, period. So therefore, if you're taking them, you should stop them when you're 60. And that is a complete misunderstanding of the science. If you started hormones in the first 10 years of menopause, we want you to continue them, because remember, taking estrogen is preventative. So you've got that benefit. You've already established healthier blood vessels by taking estrogen early. Now, we don't want to stop your estrogen, plus or minus the other hormones, right at the time when the risk of the diseases that we're trying to prevent is going up. So in our 60s and 70s, when the risk of osteoporosis, Alzheimer's, heart disease, diabetes, colon cancer starts going up quite rapidly, that would be the worst time to stop estrogen, because as soon as we stop it, we start having pretty rapid bone loss, pretty rapid vascular decline. So don't stop it. So totally different question. If you started it earlier, we just want to continue on it. I plan to take mine until the day I die, unless something comes up that is a real good reason to stop it. Like, for example, very few examples, but the obvious one would be if you personally developed an estrogen-sensitive breast cancer during the time that it's being treated, we would take you off estrogen. Now, you could possibly start it later depending on the stage and type of cancer, but during the time of treatment, you would certainly stop it. But short of that, otherwise, we would continue it. And remember, even if you're way over here on the naysayer side of this conversation, none of this has anything to do with progesterone or testosterone. So if your doctor has scared the daylights out of you about taking estrogen and you can't get that out of your head when you're in your 60s or older, you could still take progesterone and testosterone. There's no controversy about those two regarding timing. Any controversy is only about estrogen. So I hope that makes sense. If you learned something today, please don't forget to subscribe. Share it with your friends. And of course, we are seeing patients in Houston in 2 different locations. CompleteMidlifeWellnessCenter.com. We also see patients virtually, so we'd love to talk to you about this in person or virtually. And I can't wait to see you next week.